Hi everyone, can you all hear me? Yeah, brilliant. Fab. So I'm going to talk about Healthy Pregnancy Clinic, and this was a clinic that we set up about 11 months in now, so I couldn't quite get a year's data, so I've got 11 months, which is good as, I suppose. So I'm going to talk through how the clinic has developed, and also what the outcomes of the clinic are, and how they're going to be how they are benefiting women. So as we all know, obesity in pregnancy, it has come with its issues, and it's linked to an increased risk in birth complications during pregnancy and birth. And actually what we're finding is that they're at higher risk of developing DVTs, they're at higher risk of a PPH following delivery as well. So we want to make sure that these women have a good health during their pregnancy. The evidence from the Embrace report in 2016 says actually 33% of women with a BMI of over 30 died. So actually it's quite significant, and 18% of these had a BMI of over 25. So there is something to really look at there, and actually what we can do to potentially influence a woman's weight during pregnancy, and making sure that they are eating the right foods to get the right nutrients for her and the baby. So initially then, the BMI, it was called the BMI Clinic, and it was a service that was set up initially to develop to aim to reduce the obesity-related complications in women and their babies. But the first thing I did is that I was looking at the name BMI Clinic, and the women didn't attend, or they did attend, but not very many attended. So the DNA rate was really high, and it was because women were put off by the name. They didn't want to go to BMI Clinic. One woman said, "Oh, am I at Chub Club?" And I was like, actually, no, you're not at Chub Club. So they thought they were going to come and just be shouted at, which was absolutely not the case. So we weren't getting the messages across that we wanted to get across. So what they did, they were invited to attend this BMI clinic if their BMI was over 35. So they were initially labelled, and then invited to attend this midwife-led clinic at around 22 weeks gestation. So the kind of the fundamentals of the clinic are similar. So in this clinic then, they were discussed healthy eating in pregnancy and recommended weight gain as well. And our aim is to recommend that women put on no more than 10 kilos in pregnancy, so that under 10 kilos. And that'll be a healthy, and this is with the BMIs of over 35, and this will be a healthy weight gain in pregnancy. It's about 1.5 stone. So these women were then, once they came to BMI Clinic, they were booked under consultant-led care. Therefore, they had their babies on the consultant-led unit. Now, if you had a multip, so second baby, had a very normal delivery first time round, but just perhaps didn't lose any kind of baby weight after delivery, and her BMI is just creeping over that 35, she'd be going on to a medicalised labour ward, and actually probably result in a little bit of intervention there, which is unnecessary, when she'd probably achieve a very normal delivery. So what we needed to look at was actually, where are these women in the best place for achieving a spontaneous delivery? So this was just a diagram of the initial service that was offered. So pregnant women with a BMI of over 35 to 39.9 with no further comorbidities were seen in BMI Clinic and then booked into consultant-led care. So they were, again, we were discussing healthy eating in pregnancy. They were given or offered a glucose tolerance test. And what we found is that there was some, dependent on what obstetrician they were placed under, was dependent on whether they had serial scans, was dependent on whether they had follow-up appointments in antenatal clinic, or whether they had nothing at all. And then their plan for delivery was on the obstetric unit. So we did a little project, and it's called a LIPS project. So it's using service improvement methodologies to actually look at how we could change this clinic to benefit these women achieving a delivery outside of an obstetric unit. And this was in line with the prudent healthcare approach as well. So we looked at, the Welsh Government has set a target for us to having 45% of women delivering outside of, or starting their labour outside of outside of an obstetric unit. So we were looking at how we could incorporate this prudent healthcare approach as well into this clinic for these women to achieve a normal delivery outside of an obstetric unit without any necessary intervention. So, and what we found is when we were looking into this was that the clinical variance, as I've just touched on, the clinical variance. So, for example, if you had two women with both primips, both BMIs of 38, one was placed under, or they're both placed under obstetric-led care. One saw their consultant pretty much 3 weekly. They had serial scans, they were on aspirin, they offered a glucose tolerance test, and then they delivered on the consultant-led unit. The other primate, BMI 38, still under obstetric-led care, maybe saw the consultant at 36 weeks, and that was it. So how could we justify that clinical variance? So we thought, actually, we need to streamline this. So the best thing we thought to do was to take them out of antenatal clinic and out of consultant-led care if they had no further comorbidities. So obviously, if there was any deviation from the norm, they would be placed back into obstetric-led care. And then, as I said earlier, what we found is that these women were actually delivering on the consultant-led unit unnecessarily. So we did a bit of background analysis as well, and we found that actually in 2016, the data that we looked at, there was about 556 women that booked with a BMI of over 35. And this is just Cardiff and Vale. And with that, only 17 of them delivered outside of an obstetric unit. That's 0.3%. So it's a very small amount of women delivering outside that actually that could actually be raised. We also looked at the weights at 36 weeks. And we found that actually, if they were placed under consultant-led care, then the weights at 36 weeks weren't getting recorded. So we had no accurate data on actually the weight gain in pregnancy. So we could also say that, we're not giving them the kind of full care, really, if they're not being weighed at 36 weeks. We're not having an idea of what their weight gain is. So it was, we found it was quite low. Also, the women that achieved a weight gain of no more than 9 kilos is about 58.5%. So, just over half of the women achieved the recommended weight gain. So therefore, the other half didn't. Okay. Then we looked at the method of delivery, and this actually tied in with the Institute of Medicine's recommended weight gain. That actually, for women with a BMI over 35, if they put on between 3 and 6 kilos, they're more likely to achieve a spontaneous vertex delivery. So actually it ties in, so the evidence is there, and this evidence matched the IOM evidence. And then again, with women with a BMI of 30 to 34.9, these women actually do start their labours outside an obstetric unit. But if they put on between 6 and 9 kilos, again, they were more likely to achieve a spontaneous vertex delivery. So first thing we did was change the name to Healthy Pregnancy Clinic. We thought, let's get rid of the name BMI Clinic, let's revamp it and call it Healthy Pregnancy Clinic. So what we did, we asked women to attend, with a BMI of over 35, were asked to attend the Healthy Pregnancy Clinic. Some midwives still call it the BMI Clinic because that service was so embedded. So actually we're still trying to kind of encourage midwives to use Healthy Pregnancy Clinic. And here we discuss healthy eating, we discuss recommended weight gain. But we don't just discuss losing weight in pregnancy. We don't want that. We want them to maintain a healthy weight, but eat the right foods. So we do go through the Eat Well guide with them, but also set them some goals and actually look at the targets that they want to achieve. And actually it's great motivation for them. If they want to achieve that water birth on a midwifery-led unit, actually there's no more motivation than that. So, women are really receptive to this. We also look at physical activity in pregnancy as well, and actually encourage them to get active as well. And we carry out an anaesthetic assessment. So again, we're reducing the need for an anaesthetic review with a consultant anaesthetist. So if they have no further comorbidities, then they'll be placed on the healthy pregnancy pathway. And they will receive routine antenatal care, but they'll be placed on the pathway and they'll all be offered serial scans in line with gap and grow. They'll also be offered a glucose tolerance test and then a birth choice discussion at 36 weeks. So they'll come back to the clinic at 36 weeks. They're usually seen by the same people, so there'll be some continuity of care there as well. And then we will ask them about how they've got on with their diet, if they've made any changes, and we'll ask them if it's okay to weigh them as well. If there's no abnormalities detected and a healthy weight gain has been maintained, then we will support their choice to deliver outside of an obstetric unit. Women have choice to deliver wherever they want, but we will support their choice and advise them to deliver outside of an obstetric unit. So this is the new service that's offered. So women with a BMI of 35 to 39.9 with no further comorbidities are now referred to the Healthy Pregnancy Clinic. They're booked onto midwifery-led care. So this is the change. They're booked into midwifery-led care, not consultant-led care. They're all offered serial scans, they're all offered glucose tolerance tests, and they're all offered birth choice discussions with an aim to deliver on the midwife-led unit or at home. And this is just in a different form. All of the scans are carried out by a midwife sonographer as well. So again, they're seeing the same midwife sonographer, so they're getting continuity there as well. So we've got some outcomes. As I said, it's only been running for 11 months, so I would have liked to have had a year's data, but it's 11 months. So we've had 403 women attend Healthy Pregnancy Clinic, and that's an 83% attendance. So our DNA rate's quite low compared to what it was. 28% of them, so 112 of these women, were actually placed onto the healthy pregnancy pathway. And what the biggest increase we found were 98.2% of them were weighed at 36 weeks. And that was compared to 25% in 2016. So we've made a real difference there. Also, we found that women who gained over 10 kilos in weight at 36 weeks, there was 16.6% of them. Whereas in 2016, it was 41.5%. So again, they have that motivation of they wanted to achieve that delivery, that water birth on the midwife-led unit or home birth. They want to achieve that. Some more results as well. So we talk about marginal gains. So we want little bits at a time. What we found is we've had 54 deliveries so far of the women that were on the pathway. Okay, granted, most of them still delivered on the CLUs. We've still got some work to do. However, 10 of them did deliver outside of the midwife-led unit. And that's 18.5% compared to 0.3% in 2016. So we're going in the right direction. What I found really interesting was that 59.2% of them had an SVD. So actually there's more work to do that these women could deliver outside of the obstetric unit. We have the caesarean section rate, which is about in line with national averages, and induction was quite high, but it was for things like reduced fetal movements. So maybe women just were not feeling their baby moved, and obviously we've got new policies in place for that. Post dates was quite high as well, and actually we picked up 2 IUGRs, or too small for gestational aids, and actually if they hadn't have been serial scanned, we wouldn't have picked those up. So it was really important that they did attend the clinic and they did have those scans. What I thought was really interesting, we also picked up 6 breaches. And again, these may have been undiagnosed breaches if they weren't scanned. So if they weren't on the pathway and they weren't being seen in clinic. The main reason for transfer from midwife-led unit to consultant-led unit was meconium. So it wasn't actually obesity-related transfers. So again, we thought that was really interesting. I've also got some cost savings as well. My head of midwifery is always saying that we need to save some money. So I worked out some cost savings of this clinic. And I'd looked at it of 2 antenatal clinic appointments with midwives and 2 antenatal clinic appointments with consultants. And what we found is there's a saving of £9,184 just by taking women out of main antenatal clinic. And that's just based on 2 appointments. So actually, if you look at, maybe we could add to this and add the anaesthetic review in there and see if we're actually saving more. So like I said, it's all marginal gains. And then the deliveries, again, like I said, they mostly delivered on the CLU. However, there were some that we did have 1 home birth and we had 9 MLU deliveries. And the saving for that was £2,470. So what we did is we actually saved £11,654 in 11 months. So I think we've got actually out of the 54 deliveries. So I think we're going in the right direction. We want to carry on with this and we want to continue to support women's choice. Any questions? Hello?
How was the decision made for how many weeks you first see the women at the healthy pregnancy?
Yeah.
I mean, my thinking is if you saw them earlier, maybe you would have better success in weight gain.
Absolutely agree with you. And we were looking at this clinic continues. Sorry, Sue, I completely jumped in on your job then. This clinic is continuing to evolve. So what we're looking at all the time is how we can improve this, and we'll be using service improvement methodologies to look at different gestations to see the women, when's best to see them. What we did find is that would the DNA rate be higher if we saw them earlier, because they've already got a lot of appointments to go to already. So actually, would they then be interested in a healthy pregnancy appointment? So again, we'll continue evaluating it and see whether, and we'll ask the women. I'd like to do a patient story on this actually and see when is the best time, and we'll ask them.
That's great. Now remember, you need to wait for the microphone, stand up and ask your question. So,
That was my fault.
Hi, I'm Kate. I'm a midwife in Cardiff. I'm just wondering, do you evaluate the women's point of view, and could you potentially then provide that to the 17% DNAers to make them encourage them to come along more?
Yeah, I think absolutely. We do, like I've just said, we do want to do a patient story. We actually want to follow a patient through their pregnancy journey, through all the appointments that they attend, and actually all that they don't attend and why they don't attend it, and actually what's put them off. Is it because they think, is it the way they're being sold it at booking, or is it the way that, is it just the name of the clinic? Is it word of mouth? Are they still thinking, are their family members telling them, oh, you're going to go to like a Weight Watchers type place? So we need to really evaluate that, so absolutely. So that's certainly a move forward, yeah.
Okay. Any other questions? Well, no.
Oh.
Hi, I'm Wendy, one of the community midwives in Cardiff and Vale. One thing I do have, my obesity rate is obviously getting up. I've had a couple of ladies who have got weighed at 36 weeks, have put on like 18 kilos, and I can't get an appointment because it's too late into their pregncy. You can talk about diet, but the damage is done. Yeah. So maybe we should be talking about it earlier. Yeah. And especially at 36 weeks, when they go to the consultant, they're not weighed. I got to weigh them at 38 weeks. That's even 2 weeks before their due date. It's even too long. Should we weigh them maybe 31?
All women are weighed at between 22 and 24 weeks in healthy pregnancy clinic. So obviously our problem is if they do miss that appointment, then potentially that weight could be missed as well. So if they have put on over 10 kilos at 36 weeks, and it's the community midwives that would pick this up, I would suggest either trying to get them into healthy pregnancy then, because we can still have that birth choice discussion. Because what we're looking at is even if they have put on slightly more than 10 kilos, okay, we would normally recommend to deliver on the consultant-led unit. But if that woman still chooses that she wants a home birth or she wants to deliver outside an obstetric unit, we just want to make sure that we can assess fetal well-being. So can the fetus be, can fetal auscultation happen easily? Can we listen into that baby easily? Can we palpate the fetal parts? Can we feel if the head is engaged? We want to know all that information, and with that information we can then advise where would the best place for her to deliver. But I agree, if we saw them earlier and weighed them earlier, we might get to see them earlier, but I think 22 weeks, 24 weeks at the moment is where we're at.
It's more the fact that there's no spaces in your clinic.
Oh.
And the date I was given was when they were 43 weeks pregnant.
Okay,
so
yeah.
Go from there. So
Yeah. I would probably suggest then you email me. Yeah.
Okay. So that's instant feedback there for you. Yes. There's a question there. So I'm used to directing someone else, not having to run.
Hi, I'm Linda. I'm from Menai and Bevan.
Hi.
We have a raised BMI clinic, whatever you want to call it, the same thing. Now, we see our ladies at 16, 28 and 36 weeks, and there's a dietitian there as well. They are still consultant-led, but our weight gain aim is 5 to 9 kilos if a BMI is over 35.
The IOM.
I wondered where you got your 10 kilos from.
Yeah, the IOM is 5 to 9, so we've gone under 10 kilos.
You've gone under the 10.
Yeah, so they can have 9.9.
Yeah. Our findings were a significantly reduced rate of caesarean sections, a significantly reduced rate of PPH.
Yes.
And maternal mental health well-being for the women, because they're so pleased with themselves at the end of it when they've maintained a steady weight gain.
No, absolutely, I agree. And so therefore the next step for your clinic would be get them onto a midwife-led unit. Absolutely, because what we found in our outcomes as well, that we didn't have one PPH. And actually that's what we would be expecting to see, and we didn't have one out of the women that have delivered. So we were really pleased. We have just tied in with the dietitians, and we're setting up food-wise in pregnancy. So women are invited, but that is regardless of BMI, all women are invited to attend the food-wise in pregnancy courses that we run. So yeah, so absolutely. So it's very similar models. Yeah, great.
I'm Zoe, I'm from Cardiff. I want to know, on the news they were saying about maybe weighing women monthly or weekly more sooner. So say, for example, I booked and my BMI was 27, but then I decide to eat takeaways every day, and put on 2 stone by the time I'm 32 weeks.
Yeah.
If I was being weighed monthly, then I could be referred to you, I suppose.
Yeah, absolutely. I think when, if you speak to the dietitians, they would say they would move away from being weighed. They would say they don't really recommend it, because actually what women don't want, we want women to be supported in their pregnancy and to feel well about their pregnancy. And if we're constantly saying, right, let's weigh you, let's say, it's like we're judging them.
It's like spinning world.
Yeah, absolutely. So we try and move away from that, really. And that's why we just do that initial weight at 24 weeks and then another weight at 36. But we will see them 3 to 4 weekly for their scans anyway, so they're always able to pop into the clinic if they want further advice or further, or they want to be weighed. It's up to them. It's their choice, but we don't want to kind of be too prescriptive with them, just because we want to kind of
I'm
be
just
happy.
wondering, like Wendy was saying, if it's, you know, you don't realise, you know, someone with a healthy BMI of like 24
Yes.
who's not going to your healthy pregnancy clinic
Absolutely.
and then obviously eats all the pies
Yeah.
and then doesn't get weighed then until 36 weeks,
it's where
and
they
she's put
go.
on like 5 stone, or, you know, she'll be able to tell that by then, but you know what I mean?
yeah,
I
community
can't
midwives-
do anything about it, can I?
No, it's true.
So
Community
if I
midwives
was...
have got the choice to, if they wanted to, if a woman presents in their clinic and they say, I think I've put on loads of weight, there's no reason why a community midwife can't weigh that woman
to
and actually
find
make
out,
an
'cause you're not
assessment
known.
there.
And then you're told, oh, you've put on 12 kilos, so you
Yeah.
can no longer be midwifery led, and everything else was straightforward. But it's not until that point. Do you see what I mean? And
Yeah, so
then
we wouldn't,
You can't corner it down then, can you? You haven't got much time.
Yeah, we wouldn't necessarily just say to them, you can no longer be midwifery-led care. We would probably just get them into birth choices and discuss it with them. It's their choice where they want to deliver.
Yeah.
We can only recommend where the safest place for them to be is. With regards to the women, I suppose, that worry me the most are the BMIs of 34 that put on 15 kilos. Because actually they haven't been seen, they haven't been reviewed in our clinic. However, it is down to the community midwife's judgment as well. We've all got clinical judgment. It's down to their judgment. If you feel you cannot palpate that fetal, the fetal part, or you cannot auscultate that fetal heart easily, then actually they should be referred into the birth choices clinic into the healthy pregnancy clinic. If, however, you've got a woman with a BMI 34 who's put on 15 kilos, actually, but it's a very easy palpation, very easy auscultation, she's had a previous normal delivery, there's actually no reason for you to send her into my clinic. You can have that discussion with her and actually and talk about birthplace.
What are we going to do with the 11,000?
Sorry?
The savings, the 11,000.
Oh, I know. Yeah. Well, yeah, you'll have to ask Suzanne on that one.
Another question you wanted me to run about. I've got my pedometer on, so I know.
Hi, I'm Linda from
Hi.
Pembrokeshire.
Hi.
Just one of my findings of my patients, a lot of girls don't know how to prepare healthy food. Do you give any recipe advice to these girls, or any advice on preparing food? Because a lot of them have been brought up on chips and pies and
Absolutely,
don't
yeah.
know how to cook or prepare
you're very
healthy
right.
meals.
Yeah, we had a lady in clinic the other day eating chips before she came into the appointment with a can of Coke in her hand. And you're like, where do you start? So actually, you're very right. They sometimes don't know how to even cut an onion and prepare. So that's why we offer the Foodwise in Pregnancy course for them to attend. But if they don't want to attend that, and it is difficult to attend groups, then we do offer meal plans, and we give them recipe cards and actually talk through. I've written out meal plans for people before as well, just so they have a real understanding of the nutrients that they need to have. And actually, they're really receptive to it. They want to know, because if they're in their family, and we try and say, cook for your whole family, or if you live with your parents make sure that all the family eat the same, so they're not being kind of segregated off, and because they just won't stick to it then. Yeah.
I'm taking Chair's action, asking that, because it's interesting that we're talking about the women who've already got a high BMI, but you're very conscious that women don't necessarily eat what they should, and they're quite slim-like now.
Yeah.
And then there's a lot of evidence that women just get bigger and bigger after they've had a baby.
Yep.
So there's a sort of play. I don't know about the healthy eating group, whether that's something for all women to join or just the women with a higher BMI.
Yeah, so food-wise in pregnancy is for all, so it's regardless of BMI. And what we want to do is looking at this model. We needed to start the model somewhere. So this has only been running for 11 months. So we want to start this and actually move this model onto different aspects of antenatal care, but also for the women with low BMIs, because what we're finding, if you've got a BMI of 18 or 19, maybe they're not eating the right things either. So it's about tackling the low and the high and everything in the middle eventually.
Healthy all the way through.
Yes.
Thank you very much.
Thank you.